Hello, good day everyone. Today I'm coming to talk again about Mr. AW and his amended clinical plan. As we said before, Mr. AW is a patient who suffered from non-ST elevated myocardial infarction 6 months back, and he came to the clinic to seek prevention from secondary attack. The past medical history for Mr. AW, he had hyperlipidemia for more than 3 years, type 2 diabetes 3 years, hypertension, and headache. His current medication is metformin, 500 mg PID, carvedilol 6.25 mg PID, atorvastatin 10 mg once daily, and ibuprofen for headache. So the goal of the therapy is to control his blood pressure, control his lipid profile, control his diabetes, and also to manage his weight, plus to make him adhere to his medication. For his hypertension, as we said before, his blood pressure is not controlled, and that's due to the dose he's taking from carvedilol alone, which is apparently not enough, and also his lifestyle has to be changed. The recommendation, the target is to be less than 120 over 80. The plan: keep carvedilol 6.25 mg BID, add lisinopril 10 mg once a day, and change his life to the healthy lifestyle. Rationale: the recommendation is supported by many RCT, randomized clinical trial, and meta-analysis. ACCORD, for instance, is one of the largest trials, which studied 4,733 patients with type 2 diabetes who were randomly assigned to an intensive control of blood pressure with systolic less than 120 versus control versus standard control systolic less than 140 millimeter mercury. Although there was no significant difference in fatal or non-fatal myocardial infarction rates between both groups, but intensive control group was associated with reduction in annual stroke and non-fatal stroke. Moreover, beta blocker in patients with established cardiovascular disease will reduce morbidity and mortality, as carvedilol is one of the preferred items as a new compared to the conventional beta blocker. Adding ACE inhibitor as lisinopril with standard therapy, that will gonna definitely reduce the acute myocardial infarction and improve survival in hemodynamically stable patients and lower risk of death by 11%. The patient has to have a follow-up, so we have to encourage the patient to take daily reading of blood pressure if targeted blood pressure is not achieved, and increase the dose of lisinopril every 4 to 6 weeks up to 40 mg if needed. And also we have to educate the patients regarding the initial side effects which may accompany the lisinopril initiation, as dizziness and cough, which will go away with time. For the dyslipidemia, as we said before, the patient has a non-controlled dyslipidemia, lipid profile, and as he used atorvastatin 10 mg once daily, and according to the American Heart Association, this treatment is subtherapeutic and inadequate, and is also consuming fast food and red meat, and he has a sedentary lifestyle. So we have to have a target. LDL, created cholesterol, should be 70 mg per deciliter. Plan: atorvastatin initially start with 40 mg once a day for 4 weeks, then evaluate lipid profile, increase to 80 mg if targets not achieved. If side effects are not tolerated, consider combining with ezetimibe. Lifestyle modification and weight management should be enforced. Rationale: according to the American Heart Association 2018, AW is considered with a very high-risk group, previous atherosclerosis cardiovascular disease 6 months ago, and positive history for diabetes. Additionally, his total cholesterol level is 210, which is classified as a severe hypercholesterolemia. According high-intensity statin therapy should be initiated in order to achieve 50% or greater reduction in his LDL. Therefore, maximizing statin dose is recommended. Moreover, high-intensity statin therapy should be initiated for men and women less than 75 of age with like atherosclerosis cardiovascular syndrome. Randomized trial of LDL-C lowering drugs, including statin, ezetimibe, have shown a reduction in cardiovascular events. However, it did not show a mortality benefit. The patient also should be educated that the side effects of the medication. Most patients with statin therapy might experience fatigue, muscle pain. The patient should consult the physician when experiencing such symptoms or any darkness of his urine color. You should avoid grapefruit, as grapefruit juice with statin will increase the statin level and will lead to side effects more promptly. Third thing we need to control is diabetes. As we said before, fasting blood sugar is 200 milligram per deciliter, and his HbA1c is 9.4%. Patient is diabetic and not controlled. Patient diabetes mellitus is not controlled for the following reasons. Patient is currently on metformin alone, 500 milligram PID, appropriate but subtherapeutic. Also lifestyle and the food choices. Recommendation: we will need to target blood sugar 7 to 8%. We need to maximize metformin dose to 1,000 milligram PID and add sitagliptin starting with 50 milligram PID. The patient is having a problem in compliance, so we can consider Janomet, sitagliptin and metformin combination, one pill taken twice a day. Lifestyle modification and weight management should be also involved. Rationale: standard glycemic care has a better prognosis than intensive control, according to a core trial which includes 10,251 patients with long-standing type 2 diabetes, stopped after 3.7 years due to increased mortality among the group with intensive glycemic control, average 6.4, compared to standard glycemic control group, average 7.5%. So, of course, according to this recommendation, we recommend the standard versus the intensive control of the diabetes. AWHB1C is above 9, then we should consider adding another agent to the treatment. Sitagliptin is a good addition on medication, add-on medication, as it might help in losing weight comparing to other agents. According to one of the study of 1,035 patients, average of 56.5-year-old with HbA1c between 6 and 10% with type 2 diabetes on 1,500 milligram of metformin had randomly assigned to glimepiride or sitagliptin for 30 weeks, found mean reduction of 14.4 milligram per deciliter in fasting plasma glucose among sitagliptin group, where weight loss were about 0.8 kilogram, comparing with the weight gain of 1.2 kilogram in the glimepiride group. Moreover, metformin sitagliptin combination effect, the HbA1c was 2.6 versus 1.74 from the baseline. The follow-up, we need to check his HbA1c after 3 months. If it's still elevated despite weight management, medication adjustment, and lifestyle modification considered, and maybe also considering adding insulin in that case. So we need to educate the patients about the side effects of the medication, emphasize the positive impact of healthy lifestyle, educate the patient about low versus high glycemic index food plus low and high glycemic load food, and also we need to educate the patients regarding how to control his blood pressure, his blood glucose, and to check for any like low hypoglycemia or low blood sugar. In spite, it should be very rare using the metformin and sitagliptin. The other measurement, as we said before, other factors that negatively will affect the established heart disease and comorbidities will be obesity class 1, sedentary lifestyle, consuming fast food and red meat, consuming non-steroidal anti-inflammatory for recurrent headache. So to improve the quality of life and to prevent any future cardiovascular events, the treatment plan should consider the following: adding antiplatelet in case of ST elevated myocardial infarction treated with bicabbage dual antiplatelet therapy is recommended for 12 months. AW is still having 6 months window to benefit from, as we said before, from dual antiplatelet. So we definitely we're gonna recommend his treatment with aspirin 81 milligram once daily and clopidogrel 75 milligram daily at least for the coming 6 months. Rationale: on average, follow-up for 9-month-old therapy can reduce primary endpoints cardiovascular death, non-fatal myocardial infarction or stroke 9.3% versus placebo group 11.4% as per Q trial, which is 12,562 patients with acute coronary syndrome randomly assigned to clopidogrel or placebo in combination with aspirin. Regarding lifestyle modification, diet change, fast food can provide high amount of sodium, as we know, which will increase blood pressure. According to the American Heart Association guidelines 2013 on lifestyle modification to prevent cardiovascular disease, stated adults might benefit from diet change to lower their blood pressure as following: consume more vegetables, fruit and whole grain, and fish, limits intake of sweet, sugar, weekend beverages, and red meat. Grade A, strong evidence. Lower sodium intake, grade A, no more than 2400 milligram of sodium per day. Target is less than 1500 milligram per day. B, evidence. Increase in the physical activity can reduce LDL cholesterol ratio from 3 to 6 milligram per deciliter. Moderate evidence. Lower blood pressure by 2 to 5 over 1 to 4 millimeter mercury. High evidence. One of the suggested regime is average of 40 minutes of aerobic exercise, brisk walking for at least 3 days a week for at least 15 weeks to see a good change. So patient educations, gradual increase, as we said before, in exercise is very important. Intensity is advised at the beginning. Gradual intensity is advised at the beginning, and then we increase it slowly. Also observe any symptoms of shortness of breath, chest pain, stop exercising immediately, and use nitro spray and ask for help from 911. Weight management. According to the American Heart Association 2013 guideline, weight management can positively affect the quality of life as follows: 3-gram weight loss, an average reduction of 15 milligram per deciliter in triglycerides, while 5 to 8 gram weight loss can achieve 5 milligram per deciliter in lipid LDL cholesterol ratio, and 2 to 3 milligram per deciliter in HDL to cholesterol ratio. In overweight and obese adults with diagnosis of type 2 diabetes, reducing weight by 2 to 5%, with or without orlistat, reduce the risk of developing type 2 diabetes by 30 to 60%. High strength of evidences. Regarding the headache, we need to address the cause of the headache, as we said before. Meanwhile, switching from ibuprofen to acetaminophen, we can maximize the acetaminophen to 4 gram per day to control this headache. Rationale: non-steroidal can cause an increase in blood pressure and accelerate kidney damage in case of diabetes. Also, influenza vaccine. According to guidelines, patients with cardiovascular disease should have an annual influenza vaccine class 1 level of evidence B, with annual pneumococcal vaccine should be considered after age of 65. Thank you very much again for listening. All the references been used in this presentation is listed at the end of the presentation. Thank you very much and have a wonderful day.